Welcome to Basic Pharmacology. In this first block, we're going to review the concept of pharmacodynamics. And pharmacodynamics really discussion about how medications work, how they work at primarily receptors, and we'll talk about the nature of those receptors in more general terms. At the beginning of each of our slide decks, we have our objectives, and the objectives are helpful for all of us to go through periodically. But I'd encourage you, as you look at how to approach, how to study this content, that you review the objectives that are listed here. And for each objective, be able to explain in 3 to 5 sentences to someone who is not in healthcare or doesn't have a science background to explain to them that principle that's laid out in the objective. And I think at least if you start there, that you get the framework of basically understanding these concepts, that will go a long way as you build on more detail throughout both pharmacology and later in the year in therapeutics. For this first set and throughout the pharmacology slides before we get to therapeutics, it is pretty common that I will use a bit of detail in practice to explain a general concept. At this juncture, it's probably more important that as you recognize it, you get a 30,000-foot view of the principle we're talking about and don't get too caught up in the detail. And not every slide where I do this, but a number of slides where I talk about details in the slide, but we're looking for you to get a 30,000-foot view. You may find that I've put an image of a jet. So to remind you, just pick up the sort of the global principle that's being expressed here and don't worry about the detail. So again, focusing on the big picture when you see these little 747 jets. So let's talk a little about pharmacodynamics in general. There's lots of different theories about how drugs work, but most drugs are thought to really work at an interaction between the chemical or the hormone or the drug and receptors throughout the body. And these receptors are located all throughout the body. Most of the receptors that we think where drugs work happen on surfaces of cells where drugs can get access to them, but there are certainly exceptions to that where some drug receptors work on an intracellular mechanism or somewhere else. The nature of interactions between a drug and a receptor is basically that there's almost like a lock and key nature, that there's a specific portion of the drug molecule or a hormone that works at a receptor. For example, an insulin receptor where insulin as a hormone may bind to. And there's the portion of the molecule and the portion of the receptor that have most often electrical charges in a three-dimensional configuration. Positive and negative charges are configured in such a three-dimensional way, almost like a lock and a key. And so we'll talk about this concept and reinforce this concept periodically throughout pharmacology. So after a drug gets absorbed in the body and it ultimately gets to wherever the receptor is, most receptors, we have to get the drug first to the bloodstream, and then it has to distribute out to wherever the receptors are and wherever those tissues are. We'll talk about those concepts of how to get the drug to the receptor in the second block called pharmacokinetics. But most drugs work as either an agonist or an antagonist. An agonist is a drug that binds to a receptor, usually in a weak electrical attraction where the negative components in a three-dimensional field on the drug have an attraction to a spatially similar three-dimensional positive charges on the receptor. And an agonist, when it attracts and binds to that receptor, produces some usually measurable physiologic response. That may require a number of those receptors at any moment in time to be occupied by that agonist before you see a meaningful response. And the more receptors that are occupied by an agonist at any moment in time, maybe the greater the physiologic response might be. Similarly, we have antagonists. Antagonists are drugs that bind to receptor but don't produce a physiologic response. Most often, antagonists just occupy a receptor but prevent an agonist or a naturally occurring hormone that serves as an agonist from binding to the receptor and therefore blunts the effect of what an agonist or that hormone would normally do. So let's look first at an example of a classic agonist is epinephrine or adrenaline. Adrenaline is, or epinephrine is secreted in the bloodstream by the adrenal gland in times of stress. And epinephrine binds in a three-dimensional attraction to a number of receptors. And one of the receptors it may bind to is the beta 1 receptor, adrenergic receptor in the heart. And when enough epinephrine binds to this receptor, it's attracted in a configuration, a three-dimensional configuration with electrical charges. When enough epinephrine binds to this beta 1 receptor in the heart, we'll see an increase in heart rate. So as we look at the drug, epinephrine binds to or has a configuration in a three-dimensional attraction to this receptor. It begins to, in a very minute moment in time, get attracted and then ultimately fit into that receptor with this three-dimensional positive-negative charge configuration, producing a drug response. And the drug response that's seen when epinephrine binds to a beta 1 adrenergic receptor in the heart is an increased heart rate. Epinephrine, though, binds to other receptors in the body that are similarly three-dimensionally configured to the beta adrenergic 1 receptor. There are beta adrenergic 2 receptors in the bronchioles, and when epinephrine binds to those receptors, we see a bronchodilation, a relaxing of the smooth muscle around the bronchioles that helps to open an airway. We also see epinephrine has an affinity for more adrenergic receptors, a subset of receptors that is three-dimensionally similar but not identical to these beta 1 and beta 2 receptors, called an alpha 1 receptor. And when epinephrine binds to this alpha 1 receptor, we see vasoconstriction happen. So epinephrine is actually a great drug for a number of purposes. If you think about somebody who has an anaphylactic reaction to a bee sting, for example, the two receptors where epinephrine will cause an almost immediate effect, one is in the blood vessels causing vasoconstriction at this alpha 1 receptor, and also at the beta 2 adrenergic receptors in the bronchioles, opening up the airway if someone has bronchoconstriction to their anaphylaxis. Unfortunately, the epinephrine also binds to the beta 1 receptor and may increase heart rate, which doesn't really, in the case of anaphylaxis, offer any additional real benefit for what our goals of therapy are. But as you can probably already imagine, we'll use drugs to augment existing receptors in the body to produce a physiologic response as a mode of treatment or modulating a body's response to a particular condition. So really that's all we do with drugs and receptors, agonists or in a moment we'll talk about antagonists, is we modulate a physiologic response using drugs that bind to these specific receptors. It's really as simple as that. So agonists bind specifically to a receptor with electrical charges. Usually they're weak. Usually they only bind to the receptor for a very minute moment in time. And if at any moment in time enough of those receptors are occupied by an agonist, you'll see a varying degree of physiologic response. The more epinephrine we give to somebody, for example, in a cardiac code blue situation, the more likely it may offer benefit at stimulating the heart at the beta 1 receptor to move from asystole or no heartbeat to a heartbeat. Or if epinephrine is given to a patient with an existing normal heartbeat, you would expect a little epinephrine binding to the beta 1 receptor to increase heart rate a little bit. and more epinephrine as it binds to more of those receptors at any moment in time to cause a greater degree of elevated heartbeat or tachycardia. Let's now look at an example of an antagonist. There are a number of antagonists. In the example here, we're going to use what's called a beta blocker. In this case, it's a beta 1 and a beta 2 blocker. It's very specific only for a subset of these adrenergic receptors, the beta 1 receptor in the heart, the beta 2 in the bronchioles. When propranolol binds to the beta 1 receptor in the heart, what happens is really not very much. You don't see a drug response. But what physiologically happens is actually you do see a drug response. What you see is a slowing of the heart rate. It's not that the propranolol itself slowed heart rate. It just occupied a number of these beta 1 receptors where normally epinephrine would have raised heart rate, and there's a little bit of epinephrine or norepinephrine floating around all the time binding to beta receptors. And so by blunting, by occupying a number of these receptors and taking up space, by default, it will decrease heart rate. Another example of an agonist and an antagonist would be heroin as an agonist and an opioid receptor, and Narcan or naloxone as an antagonist. So heroin binding to mu receptor and other receptors in the brain, among other things, will cause a reduction in respiratory rate, in breathing rate. By giving Narcan to someone who has a lot of heroin, heroin's popping on and off the receptors as an agonist, slowing down respiratory rate. Narcan will occupy some of those receptors, so not all the heroin can bind to the receptor at any moment in time, and lo and behold, someone's respiratory rate will improve. That's basically how agonists and antagonists, in a sort of simplistic way, work. The nature of these receptors, there are 4 concepts, and I think it's important to remember these 4 principles that happen in most drug receptors. First of all, drugs really don't do anything that the body doesn't already do. What most receptors do is they augment an existing receptor. When we discover new drugs or new drugs with novel mechanisms, it's because somebody's identified a new receptor and a way to manipulate that receptor. But it's not that the body generated some new, usually, that generated some new receptor. Although, we will see situations where perhaps with genetic mutations and the like, there could be some possibility for that. That's not routinely seen. What we do see, though, is that we see that when we give a drug that modulates a receptor as an agonist or an antagonist or something in between called a partial agonist, there are 4 kind of things that we'll expect to see. First of all, we'd expect that it's almost all drug receptor interactions, binding of drugs to receptors, are almost all reversible. The reason is that most of the attraction of most drugs to most receptors is only by a weak electrical attraction, where the positive and the negative configuration of the drug attracts to the opposite positive and negative configuration in the receptor. So drugs are binding on and off receptors instantaneously in these tiny moments, nanoseconds of time. So most drug binding to receptors is reversible. There are a couple of examples where that's not true, and throughout therapeutics, we'll give you a couple examples where instead of a very weak van der Waals force kind of binding to a receptor, we're going to see, in fact, a stronger covalent bonding happening that requires energy to break that bond, but that's unusual. Okay, so almost all drug interactions are reversible. Secondly, drug interactions are typically very selective. They're very specific. The drug's 3-dimensional configuration with charges, electrical charges, is a 3-dimensional configuration that is sort of inverse in positive and negative charges to the receptor. So drugs are very specific for the receptors they're going to bind to. Insulin will bind to an insulin receptor on the surface of the cell, and when insulin binds to that receptor, lo and behold, what happens is that a little gate opens and allows glucose to enter in the cell, so the cell can do its energy production. Insulin won't bind to these beta receptors because the configuration of insulin in a three-dimensional electrical charge field doesn't match up with the configuration of adrenergic receptor. Okay, so they're reversible, they are selective. The third issue is that almost all drug receptor interactions are graded. There's not just one single receptor, beta 1 receptor in the heart. There are many, many, many of them. So that if we have a drug agonist at a receptor, a beta 1 receptor, we occupy 10, 20% of those receptors at any moment in time. We may see some elevation in heart rate, maybe 3 or 4 or 5 beats per minute. As we increase the saturation of those receptors being occupied at any moment in time, 40, 50% of the receptors occupied by the agonist, we're going to see a further increase in heart rate, maybe 20 beats per minute. And when we've occupied almost all of the receptors at any moment in time by giving a lot of the drug, we typically see a even more dramatic physiologic effect. However, almost all receptors, not true for everything, but almost all receptors, you can get a point where once you occupy all of those receptors, you don't achieve any further physiologic response at that receptor by giving more drug. So we see that these drug receptor interactions are reversible, they are selective, they are graded depending on what percentage of receptors are occupied by an agonist or antagonist at any moment in time. And then the physiologic property we'll see happening depends on whether the drug is an agonist, binding to a receptor and producing a physiologic response, or antagonist, most often drug binding to the receptor, occupying space, but not producing effect. By very nature, by occupying that receptor, prevents an agonist from binding at the same time. And then there are drugs that are partial agonists, and they can either be partial agonists in the sense that they have a less complete binding to that receptor, or they bind only to a subset of those receptors in a particular way that is different from an agonist or an antagonist. And I wouldn't focus too much on partial agonists at this point, but we'll give some examples of differentiating a few drugs that are partial agonists compared to agonist or antagonist throughout the year. So as we kind of go through this, we talked about that drug and receptors are reversible interactions. They're selective, they're graded, they're agonist or antagonist. Just keep in mind that most receptors are fairly large molecular structures. Most of them are either on the surface of the cell or in the cell. Maybe the receptor is involved in a metabolic process in the cell, does something else. But that interaction between the chemical or the drug or the hormone and the receptor itself triggers some kind of a response. And so, you may see some variation in that, whether it's antibiotics affecting bacterial cell walls, which we don't have, or some other kind of physiologic property. Most drugs, though, bind to receptors. Occasionally, drugs alter an environment that's not really at a specific human receptor. So again, penicillin affects bacterial cell walls. We don't have cell walls, so it doesn't affect us in that way. We have sometimes that the drug doesn't really bind to the receptor but changes pH or acidity, like antacids do, or affects oncotic pressure of some way that doesn't really bind to receptors but affects fluid balance in the body or something like that. And we'll talk about those examples, but those are less common and not the classic kind of principles that we want to sort of drive home today. So the nature of drug receptors, this drug fit has to be almost perfect. It's this three-dimensional fit. If you imagine holding your left hand, spreading your fingers apart, open palm up, and looking at your index finger and your pinky and your thumb and imagining they have positive charges, and then take your other hand and hover over it in a similar way and imagine where the positive charges are in a three-dimensional left hand, the drug or the receptor in the three-dimensional right hand almost lines up perfectly in this three-dimensional sphere. And then you see this attraction because of this almost perfect fit. So that's going to be an important consideration for us to think about. The drugs are going to work because they are chemically three-dimensional structures. The nature of these kind of interactions and the specificity of that binding to receptors and what specifically happens in the cell, we'll talk about for the next 4 or 5 slides or so, but I don't think that it's critical for you to kind of spend a lot of energy on that. I think as a clinician, what you're going to be most important is to recognize a basic understanding of how drugs work at receptors, and that when you give a certain drug, you see a certain agonist or antagonist effect at that receptor, and then you can predict what the physiologic properties are going to sort of happen when you give that drug. So that will become sort of more sort of evident as time goes on. So the nature of these drug receptor binding, keep in mind that drugs don't really produce new biologic systems per se. What they do is they augment an existing receptor biologic system. And then the nature of the chemical structure of the drug can affect how much affinity there is for that drug for the receptor, maybe even how long it stays bound to that receptor. But those are things that are, as a clinician, probably not as critical for you to kind of spend time talking about. What is kind of important to sort of see is in a broad terms is that drugs binding to receptors, that nature that once you saturate, that most of the receptors are occupied by a agonist or by an antagonist, typically you're going to see the maximal response you're ever going to see. And so this is kind of a common phenomenon, for example, when we're trying to manage a patient who has hypertension. So they have high blood pressure, and our goal is to get their blood pressure in a goal lower blood pressure. We're going to give increasing doses of our first antihypertensive drug, which may work at a particular mechanism or receptor. But it's not uncommon that we get an improvement in blood pressure, but we don't get to our goal blood pressure even with the maximal dose of that first antihypertensive drug. And so once I've really occupied most of those receptors over time, and I've achieved the maximal response I'm going to achieve with that drug, I have to add a second drug for treating that patient's hypertension, but I need to do it via a different mechanism, by a different receptor, by a different process, augment a different system in the body to further lower that person's blood pressure. That's a pretty common phenomenon you'll see. So the nature of drugs, most drugs will have this dose response curve we'll talk about, where the more drug we give, the more receptors we occupy, and then we achieve maybe more physiologic property until we saturate all of them, and then you don't have any more of that initial physiologic property. Sometimes the problem, though, is that once you have that much drug around, it starts binding, having an affinity for other receptors you don't want the drug to bind to, and it could have some side effects you don't really want. So we'll talk more about that as the year goes on. Almost all of the situation is not only with drug receptor binding, is not only that the binding can be saturated, but that the binding is almost always, as we alluded to, reversible based on these generally weak electric forces. So you may remember from chemistry, and we try not to do too much chemistry in this course, but you may remember from chemistry the different kind of binding forces that happen with different kinds of bonds or electrical attractions. The strongest being a covalent bond, and sort of the weakest being going down ionic bonds all the way down to just electrical attractions called van der Waal attractions or van der Waal forces. Sort of a picture of that, and sort of I joke with classes every year that as a pharmacist, that's my background, that I have to include chemical structures every so often or I lose my license. That's not really true. But here's an example you might remember from basic chemistry. In the nature of bonding, covalent bonds are very strong bonds, and they require actually a lot of energy to break those bonds. There aren't too many examples of drugs that bind to receptors via a covalent bond. The one I can really think of here that's probably important is nerve gas poisonings that involve the breaking of that bond, an energy-dependent bond to stop the nerve gas experience. And we'll use a drug called 2PM. If anybody's worked on a paramedic service, they may know that as a antidote for such circumstances. But most drugs actually have these weak electrical attractions called van der Waals forces, or maybe hydrophobic attractions, sometimes a little stronger kind of attractions to receptors. Once the drugs sort of bind to receptors, the nature of those receptors and how they mediate a physiologic change, there's lots of different sort of approaches. It's basically 4 types of receptors. I don't think it's critical you really get to this level of depth, but we'll share it. So I would be kind of aware of this, but don't focus on it. There are receptors whereby when the drug binds to a receptor, it causes a change in an ion channel, allows sodium or calcium, potassium to enter into the cell, and that might change the electrical action potential, the difference in the charge between the inside and the outside of the cell. These kind of ion channels are common for a lot of neurologic and a lot of cardiovascular drugs that are used in practice. We also have G protein coupled receptors that affect second messenger systems, cyclic AMP, ATP. We have enzyme linked receptors like insulin that affects the intake of glucose into the cell. And then there are a number of intracellular receptors that affect some synthetic synthesis process or some other kind of process within the cell itself and the intracellular response. So those are sort of 4 types of receptors in really broad, sweeping terms. Most receptors, not all, but most of receptors are located on the surface of the cell or in the cell. and when the drug binds to the receptor, it produces a series of events. And the next couple of slides sort of depict that. Again, sort of look at this as a general principle, not as a sort of memorizing or trying to get too detailed about this. So D here represents the drug and R represents the receptor. So here we have an affinity for a drug for a receptor. The receptor is on the external surface of the cell in this case, in a plasma membrane, and the drug has an affinity for that receptor. And you may or may not remember from chemistry or sort of other sort of science-based studies that there is an attraction force and there's a releasing force, and these are represented by K1 and K2. But it's just nature of, does a drug have a strong attraction for the receptor or a weak attraction for the receptor? The constants that are noted here would be higher for a strong attraction and lower for a weak attraction. Once the drug binds to the receptor, typically something else happens. There might be some transducer that leads to an effector change. And basically what that means is there's some usually physiologic process that happens that then results in some noticeable physiologic change. And then you'll see some physiologic response happening. Okay? So an example of sometimes some of those processes might be the adenylate cyclase system. That might involve signaling to G proteins, catalyzing ATP with secondary messengers. There's the phosphoinositide system, as well as a secondary system that goes through a series of events. These are, in a sense, reflected in this graphic. And again, you don't need to know this graphic. What you kind of need to know is that when a drug binds to this receptor, things happen. There are chemical reactions that happen that ultimately trigger, if this were in the heart, for example, maybe it triggers elevated heart rate. Or if it were in the bronchioles, maybe this is the chemical mechanism that triggers bronchodilation by relaxing bronchial smooth muscle, something like that. The intensity of a drug effect depends on the affinity of the drug to the receptor, the number of receptors that are occupied, and the physiologic property of that receptor itself. So, a number of drugs will produce a physiologic response, and the degree to which that response is going to happen depends on how that drug binds to the receptor, what happens when that receptor is occupied, what percentage of receptors are occupied by an agonist or an antagonist at any moment in time. So again, we've kind of alluded to this concept of an agonist binding to a receptor and reducing a maximal response, an antagonist binding to a receptor and most often just occupying the space. That's a classic competitive antagonist, where the drug occupies a receptor where then the antagonist occupies a receptor, where the agonist or a naturally occurring hormone or something can't bind to the receptor. That's competitive. There's also sometimes non-competitive antagonists. This is where a drug doesn't bind to the receptor itself. Maybe it binds to a site that is very close to the receptor, but it makes it hard for the agonist to get into that receptor, to access it, because it's close to it. And so by its very nature, the drug, the agonist can't produce its effect.